So I'd start out by saying I think my conflict of interest is obvious. And I would move on and talk a little bit more about how I see our role in this picture. And one of the things we haven't spoken about today too much is the basic sciences. The role of industry in the service of medicine is to bring those basic sciences and form them into a tool that can be used for diagnosis or treatment of a patient. This is an old picture. It's an old picture from here in Brussels in 1911. And it really illustrates all the threads in the world coming together in one place between chemistry and physics. You'll see some famous faces back there, a little hard to recognize. This very young Albert Einstein back here. And these are the attendees of the first Solvay conference. And today we're in the Solvay library. And just a note, I'm sure most of you know Solvay was a great chemist, not an academic, but a very, very advanced chemist, held many patents, and a great industrialist, inventing the Solvay process, which made soda ash, which made cheap glass possible back here. And not to overlook all of the famous people like Madame Curie over here, but there's a guy in the back row, Ernest Rutherford. And Rutherford is one of the people we could name as the father of nuclear physics. Also, the model of the atom, as it first envisioned, being made up of protons and neutrons. Essential concepts for nuclear medicine. In 1911, when this was taken, Rutherford was just a few years out from performing an experiment which would be the first time we talk about splitting the atom. And in our business in nuclear medicine, both splitting the atom is important and putting it back together is also very important to create the radionuclides that we use to treat patients. Very important person. And that's a particularly European story, and that's a man named Hevesi, a Hungarian scientist who also trained in Germany, as many of the speakers you saw today, studied with Rutherford in the UK, and then came back to Copenhagen, where he was in proximity also and in contact with Niels Bohr. And he was the first one to do an experiment with a radionuclide, phosphorus in this case. And the basic concept is that radioactive phosphorus and non-radioactive phosphorus behave the same way biochemically inside of an organism. So he tried this on rats in order to look at their metabolism. And this paper in 1935 is the paper that really starts the science that became what's nuclear medicine today and what we've talked about today. And the things we do use very small quantities of radiation to detect very important variations in biochemical processes on the cellular level. When we talk about a CT, a CAT scan, or an MR study, or an ultrasound, or an X-ray, we talk about detecting variations in tissue properties on a larger scale. Really, when you look at nuclear medicine, we're talking about biochemical processes on the cellular level, and the most effective way to do that. And we can track a compound in the body just as Hevesi did with his rats. But unlike Hevesi, we don't have to cut them up and use a Geiger counter to find out what's going on in our patients. We can use imaging and precisely pinpoint what we need to do. We have great techniques for imaging. In nuclear medicine and cardiology, we can understand myocardial perfusion of the heart. In oncology, we've talked about localizing tumors. In general imaging, even some problems in orthopedics, like an implant, a hip implant, whether or not there's infection around it, whether or not it is generating inflammation, are really well answered with our modality. In oncology, neurology, and cardiology, I'd point out neurology for one, for several years we have had very effective tracers for amyloid plaque, considered to be the comorbidity of Alzheimer's disease. And we can understand very well, we do not have a cure or a treatment for Alzheimer's disease, but without that understanding of which patients are suffering from Alzheimer's disease, we would not be able to do the clinical trials that we need to do. these are just some molecular imaging devices, and I'm not going to go into great detail about how they work, but there's something about them that's also important, and this has to do about cost. These devices are not single imagers. What we see in the first two is a combination of a CT scanner and a molecular imaging device. In one case, a single photon scanner, what we call a SPECT. In the other case, a positron emission tomograph, a PET. So if we look at just pure cost, there's the cost of a CT and there's the cost of the molecular imaging device put together. They can be used independently, but they're really best used together. On the far right is an MR put together with a PET, which helps soft tissue diagnostics, but again is an expensive individual thing. Cost and effectiveness are not necessarily related, but in the minds of a lot of people driving policy decisions, cost is the only factor that often gets looked at. So in a PET system, we use the rarest of the rare earths. Now, when we talk about the rare earths that we use in electric motors and batteries and these types of things, they're rare, but they're not really rare. Lutetium is the rarest of the rare earths. Exists about less than 1% even in rich rare earth deposits. And actually the lutetium that goes into this PET detector that I'm holding is refined, or was refined by Solvay, by the company itself, and then formed into crystals and made into a PET detector. So the legacy of Ernest Solvay still exists today in our nuclear medicine world. And I know Johannes Tjernen was talking about cost effectiveness, but why do we get beaten up on cost? And that's because usually you talk about the nail that sticks up the highest gets hammered down first. And PET scanning, if you look at cost, is that bar on the far left. The scanner itself is expensive for reasons that we've discussed. And it's going to be more expensive always than what we see in the far right, which would be an ultrasound. And there's no numbers on the chart, but these are relative comparison. And the fact that we need a radiopharmaceutical for every scan. Simply, when the accountant goes and looks at the spreadsheet in imaging, they see, that PET stuff is pretty expensive. We got to do less of that, which is exactly the wrong person at the wrong place making the wrong decision. And these decisions have to be made on the basis of treatment effectiveness, and the physician has to be making these decisions, not the accountant. But unfortunately, in many places, it is the accountant that's making those decisions. You start very early in the morning, you make the bread, and then by noon, no one wants it anymore because it's beyond being good. In the same way, making radioactive fluorine, because it has about a 2-hour half-life, means that if you start up your cyclotron in the morning, by late in the afternoon, that stuff is not useful anymore in any way to anyone. So the logistics of making PET radiopharmaceuticals has to be just in time. And that's why it has to also have many sites. You can't have a central distribution very easily for short-lived radio tracers. And you need to be able to schedule patients very well to deliver the tracer on time so you don't run out of activity. And this process is a controlled pharmaceutical manufacturing process. So all of the regulations apply, and many of them also for very good reasons, so that you have a sterile and safe product that comes out of the radiopharmacy. But it adds cost. And it adds cost because we do need those safeties. But we can also see that the value of therapy, radionuclide therapy, which we've seen in the talks before, is also valued by the pharmaceutical industry. Now, the pharmaceutical industry doesn't throw their money away at random. And this was a purchase of AAA for $3.9 billion. And just as a comparison, world market, $6 billion, purchase of AAA, $3.9 billion. That's a very substantial movement. And where I'm getting to by this is that we're at a very interesting time for the field. Just a couple notes about what I think we would all like to see as a community. The patient we saw in the beginning was a late-stage patient, a patient that really had no other options. Do we always have to treat the patient in the late stage? Or should we think about moving forward? And how do we get the funding and the patients for those clinical studies to see when and where radionuclide therapy may be the most appropriate choice? And then there's another point here when people ask about imaging. Imaging is costly. You have very expensive, complex machines, MR scanners, CTs, these PET scanners that are obviously the most expensive thing you can make. Why, do we really need this? And I usually answer that question, have you known anyone who's had an exploratory surgery lately? So 40 years ago, 50 years ago, this was how you found out what was going on. You opened them up and you took a look, with all the complications associated with that. Imaging has essentially wiped out most exploratory surgery. It doesn't really exist as a common practice anymore. And what can we do with molecular imaging? What can we do in the future? There may be other things that we can, hopefully in 20 years, turn around and look back on and laugh and say, ooh, that was barbaric. How could we have been doing multiple deep biopsy on patients? How could we be doing multi-segment prostate biopsy on patients when we could have been doing this? I wish we will be there in 30 years, 20 or 30 years. But without the consistent support of the science, we won't get there. Thank you.